Actually, Christina proposed me the role of the pathologist in the heart transplantation. So I see behind this title a topic for pathologist. So she asked me many pictures and blah blah blah. So I joined many pictures, and I'm hoping that I'm not too much blah blah blah. Let's start for that. Here, no comment, but I'm just here, just to make the view, or over here, and I am right here. Here's the view from my hospital. You have the mountain here, the lake, Geneva Lake, and that's the cathedral. And that's my view from not far away from where I live. And that's my hospital. I show you my hospital because here, Christina and some of us sold the hospital, but right now we are building a huge, building as big as this one for pediatrics. So here it's completely broken. There is a big hole and whatever. And this will be the future pediatric hospital in 2023 or 25. I don't know really. And that's the Pathology Institute. Here the agenda. Introduction, it's not very exceptional. Definition, biopsy procedure, histologic, that's the image. Some words about classification, treatments, and the end with the take-home message. 50 years ago, we did the first transplantation, heart transplantation, by these two guys in 67. And behind that, we made huge progress with the drugs, and specifically right now with the dedicated treatment against the B, the plasma cells, and then against the complement. So it's a big area with drug, and it's not over. And on your left, you can see the survival time of the heart. It's completely related with the immunosuppression drugs. Which is funny for me is to see this title on the review in 1990. Epiphenomena antibodies is epiphenomena. That was completely crazy, and because of the huge work of Terasaki and Doucet, who bring the Nobel Prize, we know now that the DSA have a big role in transplantation. Some words about the techniques. Before, it's not common sense, but it was a transthoracic biopsy in 58. Now we have, then it was arterial and venous. Actually, it's completely related with the size of the biotoma. And now we have, as you know, all guided venous access. The definition, actually, what do we expect from our report? Cardiologists and clinicians expect that to have a complete and accurate report in order to manage the heart transplant patient based on our report. So that's the field. The biopsy procedure. We, all of us, read almost everywhere that EMB, endomyocardial biopsy, is gold standard for monitoring heart function. But actually, I mean, we will go further. There is many studies, but all the time compare with the EMB. That's how you will see where I will go or enter in the discussion or to say some words. So the technical, I think it's no secret for you, but I don't know actually the people who is watching me actually now. So it's maybe too basic, I don't know. We go to the neck and then we go down to the right ventricle to then hit the septal from the right ventricle and to make with the bioptoma, take some piece of tissue from the heart. But in 2020, recently, the Spanish team tried to have a brachial access through the vein instead to go to the neck, from the neck, or to the inguinal access. The advantage of these techniques is because it doesn't hurt so much the patient, and with the numbers of biopsy, it takes there is less side effect of that, which is quite interesting. And this Spanish team also asks that, is really the gold standard procedure, the EMB? Is it really the gold standard? And here is where they go. As we know that the clinical symptom or threshold is higher than the biopsy. That's the reason why we do the biopsy, because we think that we are before the clinics or symptoms, and it's better to manage the patient and to catch all the rejection or the beginning or the early rejection. But the Spanish team tried to avoid the biopsies and to try with the comparison with the clinical and echocardiographic threshold, which we will see with in the future, but the techniques go so further and the imaging quality is so incredible that it's not impossible. Of course, I'm pathologist. I don't like this view, but it would be possible in future that some study will compare the result with not the EMB as the control, but with the clinical result. And that's not very common to have this kind of studies. Now about the procedure, the local protocol, it's just where I'm working. I'm not repeating what you can read about the ESHLT or whatever. This is the local protocol where I'm working. So we are doing during the first month once a week, and then every two weeks in the 2 or 3 months. And in the end, you can see that the patient have almost 20 biopsies during the first year. What do we need to have actually to work? We need tissues, at least 4 pieces. And we would like to have only muscles without scars or fibers or thrombus or whatever. That's the issue of the biopsies. And then we do some 3 section on the block, and we keep all the ribbons. And if we need to do immunochemistry, we reuse the ribbons between every section, and then we can do the immuno you want. The standard is H&E and Van Giesen. It's staining for the fibrous tissue. And in the local, I do the C4D on the paraffin with the 68, and I do also on the frozen. We have 4 pieces, 3 on the paraffin and 1 on the frozen. And I do both. Could explain later for what reason if you want, but this is what we do. First, for the histological findings, first of all, we need to know the artifacts. That's the main, for me, the main difficult point. I think it's for everyone. And there is different artifacts, one from the techniques, and there is 3 artifacts. One from the procedure, the post-transplant period, and the biopsy. For the procedure, you know that the biotoma tends to go all the time on the same area. And in the end, we have a fibrous tissue with less and less muscles. The second is, of course, the main one, ischemia and reperfusion right after the transplantation. And from the biopsy, the previous biopsy can induce fibrin, fibroblast in the same area before. Well, that's the artifact we have to know. Here is some example. At first week, we have here contraction bands, we have edema and absolutely no infiltrate. And I think that if a pathologist who is not used to it can easily say that there is an ischemia or an infarct or whatever. Here is still ischemia and reperfusion with contraction band. You can see here clearly the contraction band. It's quite nice. And here the lesion called due to the previous biopsy with here thrombus and granulation tissue here, and you have the muscles here. So this is not inflammation, there is no rejection, and that could be an artifact for the beginner. The artifact from the model due to the morphology. What do we have? That's the tricky one, the quilty. We have the A and the B. Actually, the quilty could be either with a nodal structure or infiltrate myocard or myocytes, we say, meaning the quilty B. The more difficult point is the quilty B, because it could mimics the 2R or mimics simply a rejection. And that's not really easy sometimes to make it, to do the differences. You have also time to times occluded arterioles, but it's just a mimicking of the elastic retraction, and could, this image could mime or mimic graft vasculopathy. And sometimes, very rarely, you can have granuloma. Here is quilty A with these nodules on the endocardium. And if you have some doubt, you can recut, or you can do immunochemistry. You can have B. You should have macrophages, some vessels, and B and T cells. So you can do the difference with immunochemistry. That's the maybe more difficult, because you have fibrous, you have infiltrate, you have granuloma, and I did CD68 over this lesion, and it's really granuloma. And actually, we can explain that because the fibers, when you put the biotoma on the tissue, on the compress, then you can bring some artificial fibers on the same area and then induce granuloma reaction. Never forget the recurrence of the disease on the graft. It's quite rare. These three diseases are very well known, common. And of course, the immunosuppression status with the viral infection you can solve by immunochemistry. And this is what I do mostly. I compare all the time with the previous biopsy. Each time I have a doubt. So it's very helpful for the quilty lesion. And by the time you know almost by heart, just by the name of the patient, you know the lesion. So for the histologic findings, you have TCMR for me. It's T-cell mediated rejection, or you can read also ACR, acute cellular rejection. So it's a kind of mix, but it's a T-cell by opposition of AMR. To set your diagnosis, you have to be aware of the quilty lesion. First, you visualize endocardium, observe the myocytes, and don't forget, of course, the vessels, interstitium. You will see why. But at the first look, you have to see the lymphocyte infiltrate and the myocytes damage. I'm not saying necrosis, but damage. And damage meaning that the size of the fibers vary. And you have also the encroachments of the inflammatory cells surrounding the muscle cells. And you can have also distortion of the architecture. So it's not only necrosis. With the T-cell, the TCMR, you have to see or to look for the cluster of cells with kind of orientation. Is it interstitial or really intravascular cells? And more your filtrate is, and bigger or significant is your rejection. But in the end, at the first look, you look for the infiltrate and you look for the damaged fibers. Here is disarray, size, and trouble of the architecture. As you can see, you have huge fibers with the size varying in size. And you can have also, you can see here with the encroachment of the T cells surrounding the fibers. You have an edema over here. So clearly this is kind of myocytes damage we can have. The encroachment here, you can see the myocytes, which is here completely disturbed by the infiltrate with the encroachment, and the architecture is completely modified. And then you look for the infiltrate. Here you have a very teeny infiltrate surrounding the fiber, or you can have also infiltrate, but not all the time due to rejection. Here is some kind of fungi. With the AMR interpretation, AMR stands for antibody-mediated rejection. We use you have to know also some artifacts to interpret the C4D. First of all, the C4D stain all the ischemia all. Ischemia tend to stain the ischemia and the large vessels, specifically atherosclerosis, and could also deposit by absorption surrounding the myocytes. And then your challenge will be to say if this infiltrate, is it in the interstitial space or intraluminal vessels. That's maybe the difficulties of the story. Here is C4D, a false positivity of the C4D. You can see that surrounding all the fibers of the myocytes, you have these green dots, and definitely it's not a C4D, a positive C4D. Here is the difficulties of the story. Is it intravascular or interstitial cells? But what you can say that when you have a linear or serpiginous infiltrate, usually it's intravascular infiltrate. Here is C4D paraffin, par it's for paraffin. You can see that you have linear circumferential deposition and almost in every capillaries. So that's the C4D positivity. What about the classification? But that's the story of the classification, because when you say 1R, 2R, I mean, some people ask me, what does it mean? R is for revised. Actually, in 1990, we used A and 1A and 1B, but we saw in a few years later that there is no big deal and specifically no indication of treatment with the clinician, and we pull the A and B in 1R and we keep the two became 2R, the 3R. And I give you the reference of all this classification, and I'm sure that there will be a next one in a few years. What is the 2004? That's the 1R stand for at least maximum one focus of myocytes damage. You can have your infiltrate you want, but only one damage. The 2R, you have more than one, and you have your infiltrate, interstitial infiltrate. And the 3R is for the diffuse one. Diffuse one, you cannot miss it. It's very simple. It's so huge that it's not really a big deal to make this diagnosis. And you have edema, hemorrhage, vasculitis. So this one, the more difficult point is the 2R as usual in every classification. So here is some infiltrate or example of rejection. You have one infiltrate. Maybe we can discuss about one damage or not, but it's a small one, 1R. And here again, you have your infiltrate. It's an interstitial one. You have no serpiginous or linear infiltrate. So it's really interstitial. It's around the muscles. And you have maybe here one lesion or damage of the myocytes. Here is 2R, and that's the point of the difficulties of the recurrent biopsies, because you have a lot of fibrosis, and within this fibrosis, you have some fibers and the infiltrate. So, I mean, we can still discuss if it's still a 1R or 2R, but the purpose of my presentation was to illustrate the infiltrate, what we can have. I did for this image these cases, I did 2R. And here is also 2R. I'm open to all the discussion, but that's the point of the classification. You can see that all this infiltrate nodular lymphoid nodules within fibrosis, and this infiltrate is not correct. But this one, we are not allowed to interpret infiltrate within the fibrosis. We don't know the reason of the etiology of this fibrosis, but we have to concentrate or to be concentrated on the muscles. So I did the 2R. Of course, I exclude the lymphoma with this infiltrate. And that's the example of a 3R, as I told you, with many damage, muscles damage. You have here eosinophils, which is also in the criteria of the 3R. But once again, the 3R first is very rare. I don't know in your place, but it's very rare to my place. Most of the time is 1R and 2R, but 3R, it's really rare. About the AMR. AMR, we split with two criteria. You have the H for histological and the I for immunochemistry. So you have the H for intravascular macrophage in capillaries, endothelial cells activated, endothelial activated cells, and some hemorrhage and edema. That's the H criteria. For the I, you have to have the C4D and the CD68 positive, or it's not and, but it's and or, and then you can have your I criteria. I see that you can see that it's more than 50% of the surface of the biopsy, linear, diffuse, and could be strong or weak as the intensivity of the signal. For the 68, the threshold is quite low. It's more than 10%, and you have to have intravascular macrophage. So in the end, when you have the H and no I, you have the one H plus, etc., etc. And the PD-MERc, you have both case, and we stand for a pathological AMR. The 3 AMR actually disappear because with this 3, usually you have the dysfunction of the heart and the patient is almost unable to be biopsied. I can discuss with you about the DSA and the value of the DSA, how I do. Usually I communicate a lot, and when I'm in front of the AMR 1, I ask for the DSA. H plus some example now. As you can see here, you can see serpiginous linear mononuclear cells within the vessels. I'm saying cells and not macrophages. Could be for activated endothelial cells, could be macrophages, but with histological, we speak only about cells. For the C4D, you have immunochemistry here. It's linear, circumferential, and it's more than 50%. So you have a C4D positivity. Here again, another case with the C4D positivity. And that for the frozen, for me, I prefer, many pathologists prefer the IF, but it's depends on what you have as techniques. But I prefer the IF, it's easier, it's more black and white interpretation. And that's the 68, which is not easy, don't more than 10% of the surface intravascular. You can see that we are intravascular, it's more than 10%, so it's an I plus. Here again, 68, I plus. And here you have vasculitis for AMR 3. And here you have a coronarpathy, an allograft coronarpathy. It was, of course, from an autopsy cases, quite rare, but absolutely gorgeous image. When you can see the endothelial layer completely infiltrate with fibroblasts, lymphocyte, mononuclear cells. So we call that chronic active. with a reference with a nephro classification, actually, because in heart we don't do this kind of classification, but it was quite, makes sense to me to call it like that. And then you have the chronic allograft also, where you have less cells and more fibrous tissue. About the treatment, we're looking my watch, it's time. About the treatment, you have for the 1R, we do absolutely no treatment, but we do a fine tuning, increasing prednisone or not. And 2R, you have the thymoglobulin if you have a heart dysfunction. For the AMR, we use IVIG and eculizumab if you have dysfunction. And for the more severe, we can introduce also the Ritux for some case. As I see the future, definitely I'm sure that all of us think about it. I don't know where we are going, but we need other tools than immunochemistry. We will see a different study if we still do EMB or not. It's depending of the clinic, of the clinicians. And of course, the non-HLA investigation will bring more power in the interpretation. What about the C4D negative and DSA positive cases? Artificial heart will come for sure. So in the end, what can I say? EMB, it's still living. It's good for us. And be aware about the artifacts can mimic and to avoid an overcall of ACR or TCR, acute cellular rejection. Don't misinterpret the previous biopsy or the quilty lesion. And of course, take a second look of your previous biopsy. I think it's all. Yes, some words. The AECVP had published this book, so I'm doing marketing right now, and you can read more than what I said in that book, and some of myself and some of the audience participate, as you can see, in the writing of this book. Here is the AECVP board. You can, I'm here. Yeah, we don't know each other, so I'm here. And this is all the stuff. We have a nice relation. It's quite nice, but badly for us, we do now by web. But before we are used to go to Rome to do the meeting, which is not so bad. And I think that's it.